Hello and welcome to the Texas Public Health Coalition Distinguished Speaker Series. Before I get to the introductions, I would like to especially thank the Texas Medical Association for providing the venue and the logistical and technical support to make this meeting happen. And I would also like to thank the Texas Medical Association Foundation for their generous support of the Distinguished Speaker Series. Today's event will feature a topic of great importance: behavioral health and suicide prevention. I am so pleased to welcome our panel of experts. Dr. Celia Neavel is a graduate of UT Austin and attended Baylor College of Medicine. She completed a family medicine residency followed by a fellowship training in adolescent medicine and developmental disorders at the University of Cincinnati. After moving to Austin, Dr. Neavel founded and currently serves as director of the Center for Adolescent Health and Goals at People's Community Clinic, which is an FQHC. She supervises interdisciplinary teams, including the school-based Manor Mustang Health Center and the Safe Children's Shelter Health Clinic. Dr. Neavel focuses on primary and specialty holistic care for diverse youth. Areas of interest and experience include integrated behavioral health, reproductive health, youth engagement, and wellness care. She is associate faculty for population health with Dell Medical School and serves as one of the co-chairs of the Subcommittee on Behavioral Health for the Texas Medical Association. Welcome, Dr. Neavel. Dr. Kimberly Roaten is a licensed psychologist and professor in the Department of Psychiatry at UT Southwestern Medical Center in Dallas. Dr. Roaten leads the Universal Suicide Screening Program at Parkland Health and Hospital System, in which more than 3 million screenings have been completed since 2015. She has authored numerous peer-reviewed publications describing the prevalence of suicide risk among individuals seeking health care and strategies for improving systems-level interventions. Welcome, Dr. Roaten. Finally, Dr. Thomas Kim serves as Chief Behavioral Health Officer for Prism Health North Texas. He focuses his considerable talents on realizing a value-based approach to healthcare through telehealth. Dr. Kim has supported a wide range of vulnerable populations, as well as provided advocacy, leadership, and content expertise to an equally wide-ranging group of organizations. He serves or has served on multiple TMA councils and committees and on the Governor's Broadband Development Council. He received his BA in philosophy from Georgetown University and an MD MPH from Tulane University. He continued at Tulane with a combined residency in internal medicine and psychiatry and general medicine fellowship in health services research. Thank you very much for being here, panel, and thank you very much, Dr. Kim, for being here as well. I'm going to pass it off, first of all, to Dr. Neavel, who is going to provide us some statistics on the current state of mental health and suicide. Again, thanks to many of you who are here today and are listening on Facebook Live. Just as this presentation stresses the importance of collaboration in improving the mental health and safety of all Texans, we collaborated in sharing best practices with you today. First, the data.
Thank you. Can everybody hear me okay? All right. So clear data can speak for itself, but we do begin with a content warning. More than 1/3 of Texan adults report anxiety and or depressive symptoms. That's about 2.5% higher than the rest of the United States. Next slide. Suicide now is the second leading cause of death in youth, so this is a hard one. A recent study found that nearly 20% of U.S. high school students seriously considered suicide, with 9% actually attempting. Our emergency rooms, primary care physicians, teachers, and first responders can attest to this increasing rate. There is a youth mental health crisis. We can imagine this overwhelming and isolating distress that youth experience, the feeling in the moment that they have no other option. And we can imagine the subsequent distress and sadness of the caring adults around them after a suicide event occurs. When we think of the over 45,000 firearm deaths in the United States, do we realize that 60% of those deaths are actually suicide? Usually from a family member's firearm that is obtainable. And of the 46,000 suicide deaths in the United States, over half of those are from firearms. These are preventable. Less than 1 out of 10 in those who actually do present to the healthcare system after deliberate self-harm actually die by suicide. That means that 9 out of 10 don't and survive. Minimizing access to firearms in that moment of overwhelming distress and having the opportunity to intervene prevents death. It is important for all of us to know that suicide is rarely caused by a single factor. There may be several opportunities for intervention and prevention, which we'll be reviewing today. People who die by suicide don't always even have a mental health diagnosis. Again, there is that overwhelming feeling of distress and isolation. Besides the emotional reverberations in the community, there is also the economic burden of $70 billion a year due to suicidal behavior. So what can we do? What is preventive? What can Texans work towards to build a circle of support and safety?
So I'm going to introduce our patient that we're going to follow through the course of our presentation today. And what happens with our patient is going to help us follow what can happen and what oftentimes doesn't happen as well as it should for our patients who need us. So Sam is 16, although he does look older. He's usually an A or B student. He's a junior in high school. He plays school and select club soccer, so he's a pretty elite athlete, and he may be good enough for a college scholarship. He is the oldest in his family, and he feels responsible. Unfortunately, his parents have separated, and they are under significant financial stress. He may not be able to afford that club soccer invitation. He worries if he should start working to contribute income to his family. There was a recent breakup with his girlfriend, who he'd been together with for over a year. Her friends are now posting rude and insensitive comments online and a picture of him missing an important soccer goal. Sam is sleeping less, he's tired, he's more withdrawn with his soccer coach and his mother and younger siblings, and people are starting to worry.
So Sam's coach suggests that Sam get a checkup at the high school's health center, since he looks tired and isn't playing well. The mother brings Sam to the appointment later that week. He is due for his annual exam. Before seeing the adolescent medicine physician, Sam completes the rapid adolescent prevention screening on a clinic tablet, and this is confidential. This allows Sam to have mental health information sent directly to his email off of the tablet. The screening results are immediately available to Dr. Smith. Dr. Smith meets with Sam and his mother, and then with Sam alone. Dr. Smith asks Sam about home, education, activities, dating, and what he is proud of about himself. What are his strengths? Sam has trouble with the last part. Dr. Smith begins addressing his stresses and worsening mood. She talks about his symptoms that could mean depression. Sam does admit that he feels guilty a lot, that he wonders what it would be like not to be around or not wake up in the morning. Dr. Smith listens and validates that this could be a hard time for a lot of teenagers. She offers compassion and optimism. She asks permission to share some of his stress with his mother and the clinic's psychology intern. Sam shrugs his shoulders and mumbles, "I guess so." After the physical, Dr. Smith meets with the mother and Sam. She explains that how Sam is feeling is common and it's not his or his family's fault. Fortunately, the clinic can help support Sam and his family. Dr. Smith will have the psychology intern, Marcus, set up a follow-up appointment. Marcus has a session with the mother and Sam alone. Marcus uses motivational interviewing and behavioral activation and helps Sam problem solve. Marcus reviews negative and overthinking. Marcus, Sam, and his mother develop a safety plan. They all agree to meet the following week. The next week, Marcus suggests that Sam could get school accommodations if his depression is interfering with his academics. Marcus also lets the mother know that the clinic has community outreach workers to help with things such as rent and housing, and the mother says she does need diapers for the youngest sibling. Dr. Smith, the physician, meets back with Sam and his mother in the future. The psychology intern reviews that while Sam has made progress, he's really still struggling with sleep problems and thoughts of not waking up. And there is a family history of depression. Dr. Smith reviews the option of medication, and the aunt had been on medication and found it helpful. And so Dr. Smith starts medication at a low dose with frequent follow-up between her and the psychology intern. After about 6 weeks, Sam's energy level and sleep have improved. Sam reports that as if a heavy backpack has been lifted off of him. He enjoys playing soccer again. He is spending more time with his friends, and he starts thinking about college. So my clinic really does have integrated behavioral health. We really do have a school-based center, and we also do have psychology interns. We also really do screen patients starting at age 12 and up every year and all the way into adulthood and adults for depression. We have consulting psychiatrists that can help us with more complex cases, and we also take advantage of community resources when things get even more complex. So what does that mean? We provide place-based, efficient, effective patient-centered care. And as a physician, I feel less burnout because I have a team. I have behavioral health specialists to talk to. We have a youth advisory council to make sure that we're youth-friendly in our clinic and that the teens and young people want to come see this. But even with all that, I still don't have enough. This is a mental health crisis. Our clinic also participates in one of the most evidence-based types of integrated behavioral health called the collaborative care model. By using repeated screening tools over and over and close follow-up, 94 studies have shown that this is an effective intervention that decreases hospitalizations. Intervening in primary care, addressing all the facets of a person's life saves money. I recently attended an IBH family medicine course, well actually last night. Healthcare is 19% of the gross domestic product in the United States. We need to do something better. We need to treat the whole person in an accessible, comprehensive, patient-centered way. We need to develop shared treatment plans that involve families, physicians, behavioral health specialists, and community resources. We need to support and initiate more school-based clinics in Texas. We also need to support training and best practices so that primary care can respond to mental health conditions. Evidence-based models exist. Let's refine, adapt, and advance these models in Texas.
So I'm going to add to Sam's story now, and we can actually leave his picture up for a minute. So Sam has now unfortunately been in a car accident. He is taken to the emergency room and has a lower extremity leg fracture and needs surgery and probably a night or two in the hospital. When he checks into the hospital at triage, the nurse, as part of the standard check-in process, asks validated suicide screening questions. And Sam acknowledges that he's had recent suicidal ideation, and in the past he's had a plan to overdose. So immediately, having heard these answers, the nurse notifies the primary doctor taking care of Sam that we need to provide extra resources and care for him and do a more comprehensive evaluation. So Sam's doctor calls the psychology or psychiatry team. They actually are able to evaluate Sam after he comes out of the operating room and do a full risk assessment and determine that he doesn't need inpatient psychiatric hospitalization, but he does need access to care quickly. He needs to be started on both psychotherapy and psychiatric medication. And obviously in the hospital setting, in the context of a surgery and a 1 or 2 night stay, maybe those things can get started, but treatment is not going to be complete when he walks out the door of that hospital. So part of what the team does then is what's called a safety plan intervention, which is an evidence-based strategy to reduce imminent suicide risk and can be done in one sitting. So that's done while he's still in the hospital. The team also gets Sam set up with outpatient care that is both accessible and affordable. We evaluate things like, can he actually get to the appointment, or is there a virtual option? We ask questions like, if you're prescribed medication, can you afford it when you go to the pharmacy? The team also, as part of the safety plan intervention, talks with Sam and his parents about restricting access to immediately lethal means, specifically firearm security in the house. All of those efforts happen before Sam and his parents roll out the door to go home from this injury. And the key point here is that Sam is a patient who did not come in for a psychiatric chief complaint. That wasn't any part of his medical picture, but the hospital proactively screened him for risk factors. So I'm going to talk a little bit more about the data that supports those kinds of practices and how maybe it can be done based on some of our experiences at a big hospital system in Dallas. So to get us started on that topic, I want to talk a little bit about ACEs, Adverse Childhood Experiences. Many of you are probably familiar with these terms and some of the factors that go into this, but you may not be as familiar with how ACEs can connect to suicide risk, both in childhood and adolescence and then on into adulthood. So ACEs are certainly associated with increased risk of suicidal behavior at the time that the event is being experienced, but then it turns out also further down the road into adulthood. And it seems to be that ACEs are cumulative in terms of suicide risk. So if you've experienced one, you certainly have some suicide risk, but if you've experienced 4 or 5, your suicide risk is higher, and that continues into adulthood as well. You can also see on this slide that some ACEs seem to be particularly associated with increased suicide risk. So any type of abuse, physical, sexual, or emotional, parental incarceration, and family history of suicidal behavior. So the first and third of those factors are a part of any full suicide risk assessment. Those are questions we always ask to help us determine somebody's suicide risk. So you can see how there's a lot of interplay between these social factors, ACEs, and then both chronic and near-term risk for suicide. So one of the things that we have to do is to figure out how to recognize the ACEs and recognize that there's suicide risk associated with that. So we've heard about some community-based programs, and we always think of the school setting as a great place to recognize these things. But the other big opportunity is the healthcare setting. So I want to talk a little bit more about that specifically. So one of the things that you may not be as familiar with, one of the pieces of data, is that healthcare contact before someone dies by suicide is very, very common, alarmingly common. So within the year prior to death, nearly all individuals who die by suicide have seen a doctor for something. In the month prior to death, nearly half have seen a doctor. And in the week before death, a quarter to 30% of individuals who die by suicide have had contact with a healthcare provider. The trick to that, though, is that they are often not seeing behavioral health providers. They are much more likely to be seeing family physicians, OB-GYNs, emergency medicine doctors. They're not seeing the people who are intuitively looking for suicide risk during every encounter. They're seeing other people. And so with this data, we know that we have to do a better job of equipping all of our providers to recognize and respond to suicide risk. We all got into healthcare because we want to take care of people, so this is not a question of not wanting to find suicide risk. It's knowing how to find it and knowing what to do when you get to it. Those are the two biggest barriers to providing good care to patients and their families. So my suggestion for improving what we do in healthcare settings to prevent suicide is to implement a suicide prevention program. And I don't think all of these programs are ever going to look the same. This is highly dependent on the environment, whether you're urban or rural, what kind of behavioral health providers you have access to. So this is not a one-size-fits-all. This is more a choose-your-own-adventure strategy to suicide prevention. But I think there are some really critical components that have to be part of every program in order for them to be effective. So the first is using a validated screening tool. You can see the tool that we picked for our program on the right-hand side of your screen. This is a 4 to 5 question tool developed by the NIH, validated for kids and adults, and specifically validated to be used in healthcare settings. So it's short and it's free, and it's available in multiple languages. That's the key for implementation in a lot of these hospital systems that don't have lots of resources. The second piece is understanding that a full assessment follows the identification of risk. So a lot of times when I speak to hospital systems, their interpretation of what I'm suggesting to them, what they imagine is a psychologist or psychiatrist sitting with a patient for 45 to 60 minutes trying to figure out what's going on in their life and whether they have suicide risk. That's a full risk assessment. That only happens after the screening says something's going on here, raise the red flag, this person needs to have a conversation. So it's a really nice way to more effectively use resources to start with screening and then progress to full risk assessment. The other piece of this that I think is really important for hospital system is optimizing the workflow. So inevitably, when I'm talking to the people on the business decision-making side of these sorts of decisions in hospital systems, their big concern is how on earth are we going to respond to all of the people that we find? It's not that they don't want to know, it's that they want to be able to take care of them, and they worry about resources in our systems right now in particular. So a couple of things that I think can be helpful with that and that we found to be helpful in our system. The first is use what you already have. So we're not necessarily trying to optimize capacity, we're trying to optimize competency. So we're not trying to ask people to do significantly more work than they're already doing. We're trying to identify the people in these systems who could be doing different things that contribute to the cause of suicide prevention. So I'll be more concrete about that because that was kind of like a very psychologist way of describing that to you. So what came up in our system is we had a cadre of licensed clinical social workers, highly competent, skilled psychiatric social workers who were not doing suicide risk assessments at all. And that's absolutely in their skill set. And so we asked them to. We gave them additional training and said we would really like for this to be part of your clinical responsibilities now. They were very hesitant on the front end, but now they own it. This is their program, if you ask them. And so I think that really recognizing who you already have in place in some of these different systems and then leveraging the skill sets to focus on suicide prevention can be a really smart, resource-friendly way to do something like this. Also, what we're going to hear from Dr. Kim, I think, is another really smart way to use the resources you've got. So when we think about telehealth, we've come a long way in terms of our ability to leverage that for suicide prevention as well. So for those of you who work with constituents who don't have a psychologist just hanging out in the hospital waiting to see patients, there are still opportunities to do good suicide prevention. We need to be leveraging the integrated care models that you've already heard about. This is a really wonderful way to improve efficiency and efficacy. And we're not talking about co-located services. We're not talking about a psychologist or psychiatrist who just happens to have an office in the same hallway as the internist. We're talking about behavioral health specialists who actively work with primary care physicians, OB-GYNs, et cetera, to actively collaborate on taking care of patients together, which is very different than co-location. The other suggestion I would make is to advocate for utilizing existing pathways and toolkits. We don't need to reinvent the wheel for this. We know what works. We need to be ahead of the game in preventing suicide, and we have the evidence base that tells us how to do that. And so if another hospital system is doing the kind of work that needs to be done in your system, do what they do. You don't have to start from scratch. We're in a very different situation with this now than we were when we started the program at the hospital where I am. In 2015, nobody was doing this kind of suicide screening, and so we did start from scratch. But now we don't have to, and there is buy-in, actually a lot of buy-in from corporate entities regarding suicide prevention. So as an example, one of the largest electronic health record clients is very invested in suicide prevention specifically and has gathered a group of national experts to build within the electronic health record modules that can be shared across all hospital systems. So even hospital systems that don't have a ton of access to lots of IT resources will be able to pull in what's already been created in other systems. We had an hour-long meeting with them last night, and I think that's going to really revolutionize things. So to further try to convince you all that this is possible, I'm going to talk a little bit about what we did at Parkland, which is where I am. So for those of you who don't know about Parkland, we're a very large hospital system in Dallas. We have probably closer to 880 inpatient beds now, 21 outpatient primary care clinics, over 1 million outpatient encounters every year, 200,000 ED encounters, so we average like 500 to 600 patients in our ER every single day. We constantly have about 40 to 50 patients waiting for a bed in our ER as well, boarding in our ER. And we did this. So in 2015, we decided to implement universal suicide screening, and we started screening every patient 10 and older for suicide risk at every single encounter in our system. So we complete between 40 and 50,000 screenings per month in our system, which is sort of a monumental kind of Herculean task, but it's also not very generalizable, right? If you're talking to constituents who have tiny hospital systems with no psychologists, we have to give them opportunities to pivot and to use the resources that they have. So I think this is one example of how to do that. You have to take the lessons from this that are applicable in a bunch of different settings. One of the things that I think was a game changer for us, that I think would work in a number of different settings, is the idea of clinical decision support. So for those of you who aren't familiar with that term, this is basically a way of creating a system for us in the electronic health record by which the front-end user who's asking the suicide risk questions then has prompts that tell them the next clinical step to take. So it doesn't automatically do anything. It doesn't take away clinical decision-making for the provider, but it does say to them, hey, your patient is high risk. You might want to think about one-to-one observation, calling the psychiatrist, and taking away all the lines in their room. So it sort of prompts users to think of all the evidence-based strategies based on the patient's responses. This didn't exist when we started our program, so we built it. And basically what we created in our system is a clinical decision support model by which the only time that we restrict patients' access to their phone, their belongings, et cetera, is if they endorse the item that specifically says, I'm having thoughts of killing myself right now. So we tried to be very thoughtful about respecting patient autonomy, decision-making, privacy, and balancing safety with that. And I think that's a lesson that can be transferable to any setting. Each hospital system or clinic can decide the best way to manage patient flow. I don't think there's one right way to do this, but clinical decision support can really make a big difference there. The last thing I'll talk about is, I think, really important, and this is the idea of using these sorts of programs to inform prevention research. So any of you who are familiar with suicide research probably know that it's very, very hard to do. It's hard to do for a variety of reasons. One, suicide is, although it's a significant public health concern, it's a relatively low base rate event, so it's very hard to adequately power research studies and use death as an outcome. So we end up doing things like looking at suicide attempts and suicidal ideation, which aren't really the same thing. So one of the ways that we can use mortality as an outcome is to actually have access to good mortality data. And this is a real problem at the state and national level. It is very, very hard to get timely, affordable, quality mortality data from this state. I just got mortality records after 18 months of submitting paperwork, responding to questions, and it's identifiable information. It has individual protected health information, so we need to be careful about that, but we don't need to be 18 months careful. And we need death certificate data that makes sense. It needs to be accurate, we need to have cause and manner of death, and we need to have contributing factors like depression and anxiety coded in the death certificates. That's critical. We cannot decide if these programs are working if we can't use mortality as an outcome and trust our death certificate data. So I will end and hand things off to Dr. Kim by just briefly saying that the situation I described with Sam in the emergency department is not typical. That is not what happens in most emergency departments in this state or nationally. It's probably only Parkland, in fact, where that would happen. But it is, I think, what we should be striving for, and I think this audience in particular can help us sort of move the needle towards that goal eventually.
So you've heard about Sam and his presentation in the outpatient environment, and then his unfortunate accident that led him to the emergency department at Parkland. And in both cases, he was receiving state-of-the-art care, integrated, serving him where he needed it and where his family needed it. We're going to now hear from Dr. Kim in another yet alternative, different venue of care, model of care, and hopefully we'll hear even more takeaways that we can emulate and potentially support.
Thanks, Dr. Terk, and thanks to all who had me, and thank you all for coming. My name is Tom. If you didn't catch the messaging, it's pretty bad out there from a behavioral health perspective. Probably getting worse. So what are we going to do about it? And I love this construct of using Sam. And the part, the third to the story as he continues to spiral downwards is because Sam's experience and Dr. Roaten's story is such an unusual outlier. In fact, having potentially screened him for this accident probably saved his life, right? And avoided costly, potentially grave consequences because they knew what they were looking for. The reality is that this accident is often missed. And the result is that all sorts of compounding negative consequences can happen, whether it's the revolving door of hospitalizations with repeated self-harm gestures, academic challenges that eventually lead to dropout or being kicked out for a variety of behavioral issues, legal challenges, whether it's group home placement, secure incarceration. The list goes on about how untended to mental distress can lead to just a worsening situation. And so the context of this is this idea of clinical decline, specifically suicide. But I'm actually going to try and pull the lens back and offer this framing. When we think about the story of Sam, which is the story of all of us, really, ultimately, the root cause is not fully biologic. It's very easy to talk about serotonin. We've been doing it since the 80s. It's very easy to talk about things. But the alternative framings of ACEs and broader social drivers of health are much more helpful, both because they tend to not label somebody as being defective in some way, shape, or form, and talks about the complexities that swirl around all of us and the impacts that they can have. And as a result, it's helpful to simply talk or consider the fractured care system that we currently enjoy. Moreover, how that fractured care system results in poor resource allocation. What limited resources we have in terms of people or things is being directed to crisis response. How many of y'all are clinical in this room? Work in a health system, have seen a patient? And then the remainder of you are legislative and or educational, correct? So I'm hoping it's not too big a stretch to realize that when you see the house is on fire, we tend to sort of put all of our resources towards putting out the fire, and that's where our focus lies. We have a focus problem because there is an endless hole of need when we adopt this crisis reaction rather than response approach to it. And so if you notice, these wildly vivid images were generated from an AI image generator because I'm trying to unlock the right side of your brain. I'm trying to provoke a response by highlighting how bad the house fire is currently. And I could not get a usable image for the following when it comes to how do I conceptualize our care system. In the simplest form, most people think of it as a 3-tiered care system that the patient accesses based on their level of need, right? This is already a challenge to navigate because if you hadn't already noticed, each domain in our care system don't necessarily share the same expectations. But it's far more complicated than that. I like to think of it as a care ecosystem where people either seek or need care in a variety of different environments. And every time a patient is forced to hop to a different environment, there's a loss of information, there's a loss of clinical progress and momentum, and tragically, there's also a loss of hope because this is a struggle. So when we think of Sam bouncing in and out of legal institutions or going to an alternative school or being repeatedly hospitalized for accidents, each time he has a stalled sort of potential for clinical recovery, and that's really the struggle, is that we have siloed areas that don't really consider what I hope to do is to bridge these gaps and actually realize what's broadly known as value-based care. So what are we going to do in this terrible situation? Well, technology offers us a potential path forward. Now, I'm sure many of you have heard any one of a number of terms regarding technology in healthcare. And while they each have some sort of nuanced definitions and significances, I like to sort of capture all of it under the umbrella of telehealth, which is the broadest term. And with telehealth, I typically describe it as a skill to be mastered. And what I mean by that is telehealth creates the opportunity for having the right doctor with the right information at the right time. That's it. The application technology to create that scenario, you'll note, does not have a location assigned to it. It's not saying it's going to find the right hospitalist or the right nephrologist or the right psychologist. It allows us to figure out who that patient needs to see, arms them with the right information, and conveys that care at the right time, which is perhaps our largest problem. Because when you hear the patient experience, especially in the mental health arena, they effectively describe a world that cares for them not one whit until they want to kill themselves, at which point all of the resources are thrown at them, but as has been described before, you get 3, 7, 14 days in a hospital, 6 or 7 pills, shown the door, good luck. How is anyone meant to recover from a system that does that only to wait for them to return? So it's not all bleak. Armed with this idea of telehealth, let's narrow the term to telemedicine here in Texas, because what can Texans do is the broad charge of this session, right? Well, if you can believe it, Texas has been a leader in telehealth and telemedicine for a long time. And I am very fortunate to have been one of the stakeholders to push through SB 1107 in 2017, which established telemedicine is medicine. What that means is there's decades-long arguments back and forth about how to appropriately regulate telemedicine. And what we were able to accomplish in 2017 is, you need rules on how to administer it. We've got those rules. They're under the code of medicine. And what this does is it makes clear that what I do as a telemedicine or telehealth physician is essentially no different than any conventional psychiatrist that you might find in the office. But good luck finding that conventional psychiatrist in the office, right? So the next legislative session led to yet another hill that we surmounted that I broadly describe as service parity. What it said was, we can't tell payers what to pay for or what services to cover. But should you cover a behavioral health service, it should not matter one bit how that service is delivered, presuming we meet all of the regulatory expectations of telemedicine. That is an important landmark to hit. Now, I'll be honest, this remains theoretical. Not everybody is playing by these rules yet, because we had a little thing called a global pandemic come through in 2020. So, do you guys remember the pandemic? Right? So, the lens that I use to assess what happened to us in the pandemic, I actually describe the pandemic in many ways as a gift to me and my kind. What I mean by that is, when I think about telemedicine, this is what happened. The sky falls. Immediately, there's regulatory relaxation across the board. All of the, candidly, arbitrary rules that were set were now no longer a problem. And people were free to actually connect with their patients the way that I've been doing for 18 years, and it was marvelous. The next thing that happened was a lot of people got kind of squidgy about fraud, abuse, overutilization. Lloyd Doggett held a session in his subcommittee on health for Ways and Means last year that I was grateful to have participated in. And most of the questions were around, well, how can we be sure that all of you greedy doctors are not going to just reach into the taxpayer's pocket and take all of the money? And my answer was pretty straightforward. Because we're not. Not that fraud doesn't exist, but when you set the rules of the game, that telemedicine is medicine, a doctor only has X number of hours to see patients. So of course, if somebody logs 12 hours of service in a single day by just checking digital boxes, which frankly was the concern, that there would just be this run on utilization charges, they would probably be pretty easy to find. That didn't happen. In the tail end of the pandemic, when the claims utilization data came out, what they found was there was an enormous spike of telehealth claims, but there wasn't a commensurate spike in overall claims. What happened was people had shifted to telehealth to the tune of 70, 80% of their activity. And over the course of 6 to 9 months, that utilization rate settled down to somewhere between 20 and 30%. That's exactly what I predicted. This wasn't without any guidance, without any rules or laws. What it was me and my colleagues used telehealth for what it was. It was a skill, a tool to be used when deemed appropriate. So that was an amazing thing to have happen. The next thing is that we're starting to get a trickle of, did it do anything, right? Just using telehealth as an alternative. I believe that we're going to find more and more publications as we move forward that there was significant cost and life-saving impacts as a result of telehealth. And I don't mean just on the patient side. I mean on my colleague's side. It goes both directions. The benefits for patients seems obvious. The benefit for small practice physicians barely able to survive through a pandemic, trying to maintain their longitudinal relationships with their patients, this was a lifesaver. And finally, this whole thing just allowed the whole incubation tank to further mature, because I'm certainly not smart enough to tell you exactly how to use technology to fix the world. I have 2 or 3 ideas, but I have faith that all of us collectively can probably come up with better ideas. And one of those ideas here in the state of Texas was the institution of what's called CPAN or PeriPAN. Anybody familiar with these programs? So in that laundry list of synonyms, the last one for telemedicine was Project Echo. These are the folks out in New Mexico who really operationalized and formalized the whole idea of educational telehealth. By allowing peer-to-peer educational opportunities through technology, what you do is you expand the scope, the reach, the impact of whatever it is that you're conveying in this educational approach. In this case, behavioral health, being such a finite resource, is made much more impactful by reaching out, taking one of me, and connecting you to a network of primary care providers throughout the state, saying, you got a question? I'd be happy to answer it. It is a wonderful use case for the educational component of telehealth. I mentioned to you briefly the idea of longitudinal care. This cannot be overstated. The notion of what the root of our difficulties and our current behavioral health crises comes down to the fact that for the folks that need the care, they don't have a therapeutic relationship with any kind of counselor or psychiatrist. I'm not saying that everybody needs one, although probably everybody would benefit from a therapist. But the idea that we are able to clear the path towards more meaningful, sustainable, longitudinal relationships, we may not still be able to meet the current need, again, because all of our focus is on the downstream stuff. But for those people that are able to establish a relationship, it can literally save their life. A final point that Dr. Roaten mentioned that I cannot, again, emphasize enough is the idea that what telehealth offers is the opportunity for true collaboration, not just digital co-location. For many, many years, we thought that we were doing a great job just planting a TV in an FQHC in the middle of rural wherever, and that was going to fix our challenge. It doesn't quite work that way. But as many of you have the immediate experience of, remote presence through things like Zoom can still create collaborative moments that we have only begun to sort of take advantage of in the healthcare space, and more is certainly on the way. And so, as an epilogue to our SAM arc, where we took a very promising young man, had a number of things going for him despite all of the pressures and the chaos and the nonsense that was swirling around him. And there were multiple paths in front of him, paths that could have allowed him to thrive rather than survive, and others where he simply fell off the path. Just yesterday, I have an ongoing patient that I've been caring for almost 2 years through the pandemic, who reached out to me saying, I don't think I'm going to make it. And I said, are you free now? And I spent 15 minutes on video chat asking what's up. Turns out, and I got his permission to say this, he'd been working 100 hours a week because he's trying to impress his boss, and it's predictably driving him mad. He's not sleeping. He was at the end of his rope, contemplating suicide, not in an overt way. But had we not had the relationship, had I not had the ability to flex for 10, 15 minutes to say, hey, here are some things that we can do, here's a plan, I'm still on the path with you, it would most decidedly take in a dark turn. This is what continues to fuel my interest in this. And again, this is sort of the broad charge. So the idea of crisis avoidance is 100% where we should be directing our attention, right? I don't have all the answers. I know the house is on fire. But if we don't start looking upstream, if we don't start avoiding the crises before they come, we will never have enough to take care of this issue. And it will only get worse. I'm so sorry for taking such a dark turn. What this will yield is something that I call a wellness dividend. When we avoid hospitalizations, when we reduce medication burdens, when we do a number of things towards enhancing wellness, that's money not spent in this thing. Now, this is not a dividend that you can cash out and stick in your pocket, obviously, right? This is going to require collaboration across multiple industries and multiple agencies and systems to say, if we don't spend a ridiculous amount of money, where is the reinvestment opportunity? Not just in healthcare, but in education, in housing, and all of the various things that Sam was kind of struggling with, because Sam is all of us, right? So, broad takeaways, and candidly, mostly for you guys in the non-clinical space. When I think about where we go with telehealth as the legislative session starts gearing up, the first and foremost is we need to have definitive guidance on regulations. The public health emergency has been kicked down the road again. The rules remain in place for a number of months, but this creates uncertainty and, frankly, hesitancy among the players in healthcare, telehealth, and otherwise that long-term guidance would help. I have very specific recommendations on what should and should not stay, but we really should come together and agree that telehealth is going to be a vital, necessary tool to get us through this crisis, and we should simply just make the rules permanent. The second thing is the hill that we didn't quite get to the last legislative session, which is around payment parity. Without an economic engine, telehealth will continue to flounder and continue to not grow and mature and develop wonderful things like CPAN and PeriPAN. I think that's pretty clear. We need good investment in our broadband infrastructure, because without the wires to connect us, we're going to be unable to care for it's still there, the health of all Texans, right? I'm very fortunate to be on the Governor's Council, and I know that they've been doing great work in the standing up of the broadband office, and I look forward to how we can further wire up the state. And then this was a final bid for excellent use cases like CPAN and PeriPAN, which are amplifying, which extend the reach of our very precious limited resources of people. Thank you so much for your time and attention, and we'd be happy to answer any questions.
Thank you very much, guys. We're going to conclude after we take some questions that were previously submitted, and we'll also have the opportunity to field some questions from the audience here. First of all, a question for Dr. Neavel. Can you please explain to everyone what we need to know about school-based clinics?
Yes, I also would encourage you all to look at our own Texas Department of State Health Services website, because they have some really nice information. So we have had school-based health centers around in Texas for a while. In the United States, we have over 2,584 school-based clinics as of 2017, and there's a new census going on right now as we speak. But these are health clinics that are near or inside schools. They're usually interdisciplinary and do include nurse practitioners, physicians, social workers, nutritionists, psychologists, dentists, dental hygienists, and administrators. And it's basically, to quote that website, which says, as school administrators said, they're safe places for students. Each day, millions of children and adolescents go to school with physical and mental health concerns that threaten their well-being and emotional performance. And issues of bullying, academic problems, substance abuse, sports injuries, sports physicals, and as we've talked about today, those mental health problems all can be addressed within that system.
Thank you. Dr. Kim, how can you compete from a quality point of view with the integrated conventional care, in-person care that's provided by Dr. Neavel? Isn't the kind of care that she's providing superior to telemedicine care?
That's a fairly simple question to answer. I would never compete with Dr. Neavel, which is to say, I don't believe that it's a zero-sum game when it comes to healthcare delivery. And because it's a skill to be offered, you don't necessarily have to apply that skill in any and every situation. Where telehealth typically takes root are the areas of highest need. Now, is that to say that Dr. Neavel couldn't use some telehealth support? She absolutely could, right? So I would reframe the question as saying, rather than looking at something as substitutive or even additive, it is collaborative, and the application of telehealth as a tool in the places that need it most can only yield a positive impact.
Thank you.
Yeah, telehealth is very important to what we do. It's that in-between time to check in with people, just as you're saying, and it reduces a lot of barriers to access. I love it.
So we did have some questions that were submitted in advance of our presentation, and one of them was as follows, and we can let any one of the panelists respond. What tools or encouragement can you provide Texas parents, teachers, and pediatricians and pediatric providers who are dealing with young people's mental health issues while also enduring their own mental and emotional pandemic fatigue?
I can start us off. So I think the easiest analogy is the one from the airplane. You have to put your own oxygen mask on before you can put your mask on your kid. So certainly encouraging good self-care, encouraging parents and guardians to actively engage in their own mental health treatment is really critical. I'll speak to the suicide prevention piece of this specifically. There are a lot of resources online for parents who want to read more about how to talk to kids about suicide, particularly if there has been a suicide in a school setting or among a peer group. My recommendation is the American Foundation for Suicide Prevention for that. They also have a lot of policy documents there too, so that's a great resource for y'all, I think. So that's the suicide prevention piece of it.
And I think everything that we talked about today answers that question, because when we're able to implement things like integrated behavioral health, school-based health centers, telehealth, learning new skills together and collaborating together so that teachers, first responders, physicians, behavioral health specialists feel like they're working as a team together, I know it reduces my burnout a lot, that we collaborate, and so these collaborative teams really can help some of what everyone's struggling with. And I think staffing cases together, recognizing that things are hard, and just acknowledging and being in that space together is really, really important for the work that we do.
A final point would be to highlight the power and the value of screening. USPSTF just came out with a variety of new updated recommendations, including screening kids and, frankly, people under 65 for anxiety, in addition to depression. So I ask all of you, the last time you saw your primary care doctor, were you screened for depression or anxiety? And if you weren't, ask yourself, is this something that I want to ask? I'm super gratified that more and more people feel more comfortable talking about the idea of depression and anxiety, and that alone, just like Dr. Roaten's work on just suicide screening, if you don't ask the question, you don't get anywhere. So I'm a huge advocate for screening.
Thank you very much. As a primary care pediatrician, we've had adolescent depression screening now recommended for quite a long time, and it is eye-opening to see the kids that we would have never guessed were struggling, that we're finding out at an earlier stage where they are and what their needs are. The second part of that is, what do you do with them when you find that they're positively screening? And I would say that the next step in broadening access for these people to receive the care that they need in their primary care setting is support for people like me to take care of these kids and learning how to take care of these kids. And there are programs out there that will help us do that, which I think would be deserving of broader support as well. So I would very much like to thank you all for being here today. I most especially would like to thank legislative staff as well as our own Representative Howard for attending today. Thank you so much, Representative Howard. And I'd like to thank our excellent panel of experts today. It is the hope of the Texas Public Health Coalition that the information provided today will inform your discussions about policies that will improve our response to the crisis of mental health, that is impacting upon the lives of so many of our fellow Texans. I have a question in the back. Yes.
If I have a constituent call my office and they're a physician or they're a school, where can I best guide them to enroll in CPAN or TCHAT if that's what they're interested in?
So I'm going to get you a definitive answer. There's a website, there are contact info. I don't have them memorized, but if you wouldn't mind leaving your card, I'm going to have either myself or one of the TMA staffers will get you all of that specific information.
Okay, thank you.
Any other questions from the audience? Representative Howard.
Thank you. And this can be later as well, but you know there's obviously an emphasis this upcoming legislative session on mental health. That's a talk from a lot of folks, especially after what happened at Uvalde. And so what you've given us today is an overview of some things that we could consider, as well as the parity issue in particular. But it would be really helpful sooner rather than later, and you may have already done this, and I'm just not aware of it yet, but to know what it is that we can do legislatively that will give us the best bang for our buck, if you will, that will be strategic, that will not be scattershot, that will actually be focused on evidence-based practices and what we can realistically do, whether that's funding issues or some kind of implementation of a program. I don't know what it is, but we're getting ready to start that session, and bills are already being written. So whatever y'all have to recommend, it would be really helpful, because there doesn't seem to be a cohesive structure to this at the Capitol that I've heard yet. And I think that would be very valuable to all of us. So thank you for that whenever we can do that.
Thank you for your comments, and I can assure you the advocacy team will give you very detailed, including my bid for payment parity, as well as the regulatory relaxations, because if we can't create school-based points of contact, create more of that ecosystem, location-agnostic form of care, I think we're just going to get more of the same. I think that sort of creativity and then the economic engine that fuels it would be super helpful.
I would echo Dr. Kim. I have every confidence that you'll be hearing from us very soon.
Terk, you may want to just mention that we have an article actually in this month's Texas Medicine that talks about Parapan and the options available. So it's a great primer, and one of our writers, Sean, is here to actually help make sure that that information gets out. So there'll be other ways to help share that with everyone later.
Thank you, Sam. Any other questions? Thank you very much for coming, guys, and thank you very much to the panel.